Hey guys, today we're going to be talking about hematology. And this is about 30 slides that we're going to go over. So it won't be too terribly long, but this is so important to know about this area. So the anemias are going to be the focus over these next slides. And what hematology is what does that affect? Well, it affects red blood cells. Most of our body's iron stores come from the recycling of iron from old red blood cells. So that's important to know. Most of our body's iron stores come from the recycling of iron from old red blood cells. Excuse me. So what we're going to be talking about for the different types of lab values for the types of anemia. So the anemias that we're going to, some of these are going to be talked about is iron deficiency, which we're going to talk about all of these in the next few slides. But we're going to talk about what the size, the color of each type of anemia, and then also what maybe some of those diagnostic test results would look like too. So when we think of MCHC, the meaning of that, and that's the acronym for mean corpuscular hemoglobin concentration. Corpuscular hemoglobin concentration. That's the MCHC. And what does that do? It measures the average concentration of a hemoglobin inside a single red blood cell. This is going to show this could be normal in many types of different anemias. And normal would be normochromic anemias. Normochromic anemias are like aplastic, post-hemorrhagic anemia, and hemolytic anemias. But this also may be low in iron deficiency anemia, sideroblastic anemia, and thalassemia. So first anemia we're going to talk about is iron deficiency anemia. This always seems to be the one that a lot of people have an understanding of because it seems to be pretty common because it's so easy to be able to get iron deficiency anemia, in which we normally see this in malnutrition, especially from like fortified cereals and things like that, or eating disorders. So iron deficiency is a microlytic and hypochromic anemia. So what does microlytic mean? Microlytic means it's really small red blood cells. Micro, think small. And then hypochromic, chromic is color. So hyperchromic means dull, lacking color. So iron deficiency anemia, microlytic, hyperchromic, small, dull red blood cell. And this is caused by disorders of hemoglobin synthesis, particularly iron deficiency. So ferritin, which also could be a lab that a provider would want to order, or that we would want to order for a patient. And this is really important measurement that reflects the body's total iron stores. So if you came to my office, I would want to monitor your ferritin level, draw a ferritin level, so we can kind of see where your iron stores are kind of at. The nurse practitioner will order a ferritin level to get an idea of the total body's iron stores, kind of what we just talked about. Low ferritin reflects anemia, but does not tell you the type. So that's why it's really important for us to have an understanding of the different types so we can kind of get that diagnosed. So major lab markers for anemia would be increased red blood cell distribution which is one of the earliest lab markers in developing microlytic or macrocytic anemia. In future courses, we'll learn more about lab markers to diagnose the different types of anemia, but diagnosing anemia is beyond the scope of this presentation right now, but it's important to know what these mean and what they might signify. Megablastic anemia, this is characterized by the presence of large. So think of mega, this is big, large. But they're megaloblasts, they're immature red blood cells. So think it's like they're so big, but they didn't have enough time to grow. They just blew up really quick. This is megablastic, like blast. They just blasted out of nowhere. They just got big and huge. And these are in the bone marrow, and a decrease in the number of mature red blood cells in circulation. These are often due to deficiencies in vitamin B12 or folate. Individuals at risk for megaloblastic anemia would be dietary deficiencies, such as like vegans, vegetarians, or ones with like poor nutritional intake. This could also be elderly, or even malabsorption syndrome, such as like celiac, Crohn's, gastric bypass. Sometimes pregnancy, due to maybe increased nutritional needs or chronic alcohol abuse. So we just think of megablastic is that they're huge, but they're not doing a lot because they're immature, okay? And this would be more of a dietary with people not eating iron at all, like none. It's just megablastic iron deficiency of like vitamin B12, vegans, vegetarians, malabsorption issues. Megaloblastic anemia, that's characterized, like we just said, large immature red blood cells. We said vitamin B12, folate deficiencies, and the types. Let's see here. Also, certain individuals with certain medications. So, megaloblastic anemia, this could also be from certain medications, such as like methotrexate. Methotrexate can treat certain cancers and autoimmune conditions, and it actually can inhibit folate metabolism. And then also long-term use of PPIs. Those are those proton pump inhibitors for the acid reflux a lot of people take for that GERD. That can actually impair the absorption of vitamin B12 from food. So that can also cause megaloblastic anemia. And then for people with a chronic alcohol abuse, that's just impaired, leading to the deficiency of B12. Folate deficiency. We just talked about how this can cause megaloblastic anemia as well, but it is important to know who is at risk. Alcoholics can easily get folate deficiency. So a lot of times in the hospital, if you have a patient that has alcohol dependency, most likely they're going to be getting some type of folic acid injection through their IV. Typically in the hospital, send them home with probably a script for tablet form of folic acid. So just to kind of put that in the back of your head, that folate deficiency also causes megaloblastic anemia. Folate deficiency occurs when there is an insufficient level of folate in the body. Folate is essential for DNA synthesis, repair, and plays a crucial role in red blood cell formation. So vitamin B12 deficiency. I kind of talked about this in a couple slides earlier about that when we were talking about megaloblastic. Vitamin B12 deficiency, what kind of symptoms can a patient experience? They can experience fatigue, dyspnea, which causes that difficulty breathing sensation. They can have peripheral neuropathy, which is that typically seen in the bilateral lower extremities, such as numbness and tingling. Who is at risk for vitamin B12 deficiency? Older adults, H. pylori infection, and then it also affects the vitamin B12 absorption. Vitamin B12 deficiency occurs when there is an insufficient level of vitamin B12 in the body. These vitamins are vital for red blood cell production, DNA synthesis, and proper neurological function. And this deficiency can lead to megaloblastic anemia and neurological symptoms. Hemolytic anemia. Who is at risk? Again, in a different video, we talked about hemolytic anemia and what kind of hypersensitivity reaction that can happen. And that can actually happen from type 2. If you remember from a previous video, it's cytotoxic type 2 hypersensitivity reaction. And hemolytic anemia is when red blood cells are destroyed. Why does this happen? Well, we talked about how this can caused by a mixed matched blood types. They're getting a blood transfusion. This could destroy the red blood cells. Autoimmune hemolytic anemia. That's due to the autoantibodies against erythrocytes that the immune system perceives as an antigen and then attacks it. And this can also be a drug-induced hemolytic anemia, an allergic reaction to a drug, which can cause it as well. Okay, so we're going to talk about sickle cell anemia. And I think a lot of people have heard about this as well, but we're going to just do a review. This is actually a type of hemolytic anemia. It's where blood cells can be normocytic, which means that they're normal in size, and during periods of steady state when not in a crisis. So the big thing with sickle cell anemia is that while sickle cell anemia can cause hemolysis, which is destruction of red blood cells, the overall size of the cells tends to be within normal range, which is that normocytic, resulting in normocritic anemia. Patients who will be encountered have a sickle cell trait. So this isn't something that like, oh, I found out I had sickle cell anemia. No, you're actually born with sickle cell anemia. And this has to be, both parents must contribute to an abnormal gene for a child to have this disorder. So that's important to know, is that both parents have to be a carrier to contribute the patient to have an abnormal gene for the child to be born with that. It's an autosomal recessive disorder, and that's actually caused by a mutation that the gene leads to the production of abnormal hemoglobin. So the hemoglobin, remember, or that sickle cell is a sickle cell shape. It's really hard for them to get through your body, and that's going to cause a lot of pain and crisis too, but we'll talk about that a little bit here. Sickle cell anemia is classified as a hemolytic anemia, which we just talked about. This is where body produces abnormal hemoglobin, which leads to the deformation of red blood cells into a sickle or crescent shape. This altered shape results in several complications. It can actually cause reduced lifespan on red blood cells. So normal red blood cells have a lifespan of about 120 days, whereas sickle-shaped cells typically only last for 10 to 20 days. Guys, that's a huge difference. Sickle-shaped cells only last for about 10 to 20 days, but in normal red blood cells in a person, they last for about 120 days. So this rapid destruction in a sickle cell leads to chronic anemia. It also, sickle shape also impairs blood flow because of the sickle-shaped cells can obstruct blood vessels, leading to reduced blood flow, pain, which is known as the sickle cell crisis, and potential organ damage. Increased risk of infections. The spleen, this is huge, huge, huge. The spleen may be damaged by sickling cells, reducing its ability to filter bacteria and increasing susceptibility to infection. So that's where you can get that splenomegaly from, because it's an absorbent amount of sickle cells that are stuck in there in the spleen. So an inheritance of pattern. The sickle cell anemia is inherited, which is again an autosomal recessive pattern. This means that a child must inherit 2 copies of the mutated gene, one from each parent, to manifest this disease. If a person inherits only 1 copy, they are considered a carrier, sickle cell trait, but they typically do not show symptoms of the disease. So, can you get a mutated gene from one parent? Yes. Will you have sickle cell anemia? No, you will not show symptoms of the disease, but you are considered a carrier, a sickle cell trait carrier. So the mutation it's a genetic mutation responsible for sickle cell anemia occurs when a single nucleotide change in the DNA sequence leads to the substitution of a valine for glutamic acid in the 6th position of the beta globin chain. I don't think we need to know that, but I just wanted to say that. Okay, the prevalence. The prevalence of sickle cell anemia is more common in individuals which could be African, Mediterranean, Middle Eastern, and Indian descent, as the sickle cell trait provides some protection against malaria. Very interesting fact. In revolutionary advantage in regions where malaria is endemic. Sickle cell anemia can present with normocytic red blood cells in certain situations, particularly during periods of steady state when the individual is not experiencing a sickle cell crisis or an acute hemolytic episode. So that's saying that sickle cells can appear normocytic, which is they're normal, they're red, they're super red and beefy, pretty red color, okay? They're not the normal size though. They're that crescent. Okay, so now we're going to talk about thalassemia. This is an inherited blood disorder, again, like sickle cell, an inherited blood disorder that causes decreased circulating hemoglobin. So there's many possible genetic mutations. The 2 types of thalassemia are alpha thalassemia and beta thalassemia. Alpha thalassemia is caused by mutations in the alpha globin genes, resulting in reduced or absent production of alpha globin chains. The severities are based on the number of affected genes. And then beta thalassemia is caused by mutations in the beta globin genes, leading to reduced or absent production of the beta globin chains. And then again, the severity would also be based on the nature of the mutations. Symptoms of thalassemia often include fatigue and weakness due to the anemia, pallor, which is that pale skin, jaundice, yellowing of the skin and eyes, splenomegaly, which can cause that enlarged spleen, and then bone deformities, particularly in the skull and face, due to increased erythropoiesis. So thalassemia, it's an inherited blood disorder that causes decreased circulating hemoglobin. So this is where you can also have that splenomegaly because they're just kind of all getting stuck in there. Management of the thalassemia depends on the type and the severity of the condition and may include regular blood transfusions. So for patients with beta thalassemia, major or severe alpha thalassemia, regular blood transfusions are essential to maintain hemoglobin levels and prevent complications of severe anemia. And then iron chelation therapy, this would be chronic blood transfusions, which can lead to iron overload in the body, which can actually damage organs. So iron chelation therapy is used to remove excess iron. Then we also have folic acid supplementation. Folic acid supplementation. This could be through different types of food. This could be with supplementation such as vitamins, folic acid, which we talked about, which is really important for people even being like alcoholics too. But folic acid, this is actually important for red blood cell production. It may be beneficial, particularly in patients with increased erythropoiesis. Bone marrow or stem cell transplantation. This is only a potential cure for severe thalassemia and is most effective when performed in children with a matched donor. Gene therapy or supportive care. Supportive care would just be monitoring for complications and lifestyle modifications, including treatment for infections due to splenic dysfunctions. So anemia of chronic disease. That is more associated with chronic infections, inflammatory diseases, and malignancies, inflammation and cytokine production, iron metabolism changes, functional iron deficiency. This can be normocytic or microcytic anemia. Anemia of chronic disease is a type of anemia commonly associated with chronic infections. This could be autoimmune disorders, chronic infections, anything that's causing an inflammatory response in the body. Iron metabolism changes. Anemia and chronic renal failure. Anemia and chronic renal failure is primarily due to a combination of factors that could be related to kidney function. And anemia is associated with chronic renal failure. Is typically classified as normocytic and normal chronic. That means that the red blood cells are normal size and have a normal concentration of hemoglobin. So while the red blood cells appear normal in size and color, their overall numbers are reduced, leading to anemia. So again, chronic renal failure patients, they're typically going to have normal looking red blood cells and normal color, but they're going to have an overall numbers are going to be reduced, leading to anemia. And this wraps up the hematology section. Good luck.